My name's Joe Holihan. I'm the Chief Medical Officer at Marinus. Marinus is a company focused on rare epilepsies and uncontrolled refractory seizure disorders. I've been with Marinus for about 4 years. My own background, I'm trained as a neurologist. I have subspecialty training in epilepsy and clinical neurophysiology, which is, in my case, the reading of EEGs to detect seizure disorders and other neurologic disturbances. I joined Marinus because I was interested in the potential of ganaxalone. I was doing consulting and had no intention in going back to full-time work, but was very impressed. I saw some phase 2 data of our compound ganaxalone in refractory status epilepticus, prolonged uncontrolled seizures. That's a neurologic emergency. And because of that, and because of the other work that was going on with ganaxalone, I decided to join the company. We have 2 formulations of ganaxalone. We have an oral formulation for chronic outpatient treatment of seizures, and then an intravenous formulation for acute use in the hospital. The oral formulation was approved for the treatment of CDK L5 deficiency disorder, CDD. CDD is a disorder that affects the maturation and development of neurons during development. It affects their structure, it affects their function, and patients with CDD develop seizures at a very early age, within the first week of life. These seizures are severe. They're refractory to treatment. One of the features of the seizures in CDD that's notable is they have what's called a honeymoon period. If they do respond initially to an anticonvulsant, that response is typically short-lived, and the seizures again recur. Patients with CDD also have a number of neurodevelopmental impairments. They have visual loss, gastrointestinal problems, developmental delay, and cognitive impairments. They have other systemic and neurologic problems like scoliosis, low muscle tone, gastrointestinal disturbances, sleep disturbances. So there's an incredible unmet need for treatment of this disorder, and in particular treatment of the seizures. So we studied ganaxalone in a phase 3 double-blind placebo-controlled trial of 101 patients with CDD and showed a 30% reduction in the seizures associated with CDD compared to a 7% reduction with placebo that was statistically significant. We also showed that ganaxalone had an effect on the severity and duration of seizures that was noticed by caregivers and parents. And so we're hopeful that CDD will have durability of effect and not have this effect that other anticonvulsants have, this honeymoon effect, where they show transient responses. So we're hoping that ganaxalone has a durable effect in the seizures associated with CDD. And it's done quite well. Gnaxalone's an analog of a naturally occurring neurosteroid, allopregnanolone. And that endogenous compound regulates mood and has other functions to regulate excitation and inhibition in the nervous system. And it's a positive allosteric modulator of GABA-A receptors. GABA is the major inhibitory neurotransmitter in the CNS, and GABA-A receptors are the most abundant receptor subtype. What ganaxalone does is it enhances GABAergic tone, GABAergic inhibition in the central nervous system. What's been shown is that in prolonged seizures and status epilepticus, the receptors that GABA binds to in the synapse, synaptic GABA-A receptors, are internalized and downregulated, so that conventional GABA drugs like phenobarbital or benzodiazepines aren't as effective. Ganaxalone binds to these synaptic receptors, but also to another group outside the nerve terminal, extrasynaptic GABA receptors. These are not downregulated in prolonged seizures and status epilepticus. So it's believed that by binding to those receptors, that's where ganaxalone exerts its action in treating seizures that have failed other agents. So for the oral formulation, we have a study ongoing in tuberous sclerosis complex, or TSC. This is a genetic epilepsy, an inherited genetic epilepsy that's due to a mutation in one of two genes, the TSC1 or TSC2 genes. This disorder is characterized by non-malignant tumors that occur in several organ systems, including the brain, also in the heart, kidneys, skin, lungs, and elsewhere. Additionally, they can have other microscopic structural abnormalities in the brain. These patients have seizures that are most often uncontrolled. And they also have other symptoms, developmental impairments, though not as severe as the ones you see in CDD. And so we currently have a phase 3 trial ongoing in tuberous sclerosis complex. We expect that to read out toward the third quarter of next year. I mentioned for the IV formulation, I mentioned refractory status. We have 2 trials ongoing in refractory status epilepticus, and we anticipate the first of those, the trial's called RAISE, that the RAISE study will read out in the second quarter of next year. This is a trial in patients who failed at least 2 treatments for status epilepticus. It's a placebo-controlled trial in the phase 3 study. And that study has 2 co-primary endpoints. One is stopping status within 30 minutes of giving the study drug, and the other is prevention of escalation to IV anesthesia within 36 hours. And so by doing that, we hope to demonstrate both the rapid effect of ganaxalone in status epilepticus, but also the durability of effect, the persistence of effect of ganaxalone. The idea of treatments in status epilepticus is not that they continue forever, that they're given for a short period of time. In this case, with ganaxalone, it's 48 hours, and that quote unquote breaks the status. And then patients remain on their chronic therapy for status, chronic anti-epileptic therapy.